Hey everyone, good morning. Hope you all can hear me okay. I am very excited to get started. I'm in a little bit of a new location this morning, but hopefully y'all can hear me. If you can, go ahead and open up your chat box and say hello where you're logging in from. All right. Good morning, everyone. We're going to get started in just about 5 minutes. I so appreciate you all joining early. Very excited for this Pump Up webinar to next weekend's two-day Advanced Test-Taking Strategies course. Feel free to check in the chat box for the link. If you want, you are more than welcome to sign up for the two-day webinar. It's going to be great. I'll be going through some of the specific details during our webinar today, but go ahead. We have about 5 minutes before we are starting. Make sure you check out that link and feel free to ask me any questions, and I'll definitely address it by the end of this webinar. If you're just joining us, welcome. Please go ahead and open up your chat box, say hello, where you're logging in from. I'd love to interact with each and every one of you. All right. Hey, Rockefeller, nice to see you. Rohit, Neha, Abhinav, Ahmed, great. And it seems like everybody can hear me, which is excellent. I'm in a little bit of a new location today, so just getting used to the tech. Wonderful. Hey, Nisha, how's it going? All right, wonderful. We'll get started in just a little bit. I hope everybody can hear me and see me. Go ahead and type in yes into the chat box if you can hear me and see me. All right, great. Everybody can hear me and see me. Great. All right. See you guys in just a couple minutes. Make sure you're putting away those distractions. Grab some coffee, grab a snack. This is going to be an awesome session. I can't wait. All right. Good morning, everyone. We're going to get started in just about 2 to 5 minutes. Thank you for joining. We have a lot of people who just joined us. I just wanted to welcome you. Excited to start this session. Go ahead and open up your chat box. I did put a link in the chat box. This session today is going to be a little bit of a pump up preview session to next weekend's live 2-day course, which is called Advanced Test Taking Strategies for the USMLE. I did go ahead and put in the link into the chat box. So if you have any questions as you're checking it out, feel free to let me know. Would love for you to sign up for that high yield advanced test taking strategies webinar. I really think it'll help your USMLE performance. That being said, we're going to get started in just a few minutes. Really welcome each and every one of you. We have so many people joining on Zoom. We have people joining from Reddit. We have people joining from Facebook, Instagram, as well as my YouTube live channel. So really grateful. This is going to be an awesome session. All right, everyone. I'll see you guys in just a little bit. Go ahead and type in where you're from. All right. It's just about 10 a.m. Eastern time. I am very excited to get started. If everyone can hear me and see me, do you mind just going ahead and putting yes into the chat box, please? Awesome. Mary, Lareb, Claire, Ruthie. Great. Well, thank you all for joining. Let's go ahead and get started with today's webinar. We're going to be going through a very high yield topic. And this is a webinar that is not only going to teach you content, it is also going to teach you strategy. And I think that the content for the USMLE is one beast, but application is another beast. And I really want to focus on application today, going through various concepts, how they're going to be tested in my signature active recall manner. All right, well, if this is your first time joining me, welcome. My name is Rahul. I am just finishing up my Pediatric Critical Care Fellowship. I am very excited that you are here because over the past 7 years, I have been absolutely passionate about helping students prepare for and excel on the USMLE in a very unique evidence-based way. Speaking of unique, I wanted to just share with you all just a little bit as to why I think my little baby Hi Guru is just so unique. I know there are so many resources out there. I really founded this preparation program and methodology rooted in evidence-based medical education literature. All of my lectures focus on active recall of the concepts that you need to know for the USMLE. I like to integrate material, and today we're going to be doing integrations with acid-base as well as endocrine, et cetera. Finally, I really am passionate both on a one-on-one level as well as through my courses on teaching you test-taking strategies so that you can think like the test maker. So when I prepare in my pass-fail course online with students across the world, I focus on this triad, and that is integrating content together, making sure you can apply that content, making sure you're productive. And that's where I have a whole preparation template on Notion, which you can definitely check out on my website. And I focus on making sure your mindset is at its peak. You're optimistic, you're positive, and you're having fun in the process. Most importantly, and we have over 100 people joining today, most importantly, Hi Guru has just become a community. And I am so grateful to have you here. I've also been very grateful to teach at top tier medical schools live, as well as even online. And now we are a global community of learners. And that is what makes this whole process so fun. We have people from Mauritius, Africa. We have people from students from the Middle East, India, United States, et cetera. This is no barriers when it comes to USMLE prep. So I wanted to share with you two important resources before we get started. Many of you right now are in dedicated study, and I wanted to highlight probably the #1 resource right now in dedicated study, and that is my USMLE Step 1 Pass-Fail course. Many of you have actually already joined my USMLE Step 1 Pass-Fail course. I'm very grateful. Hope you're enjoying the review. But if you haven't, I would consider taking a look at the videos. I'm going to be highlighting the key features of the course at the end of the webinar because I do want to get to the content, but just something that I wanted to share with you as this is peak season for studying for the USMLE. As many of you know, today's session is going to be a little bit of a preview pump-up session for the Advanced Test-Taking Strategies webinar that I'm hosting next weekend, Memorial Day weekend, 10 a.m. to 1 p.m. It's going to be via Zoom. What we're going to do is we are going to be going through 6 hours of live question breakdown. We're going to go through various approaches to questions, experimental questions, genetics questions, anatomy questions. I'm going to give you a one-on-one private tutoring-like experience in the comfort of your study space. Remember that when you do sign up, you actually get access to my test-taking strategies and productivity course. That's the 101. This is going to be the little bit advanced. So I'd encourage you, as soon as you register, you'll get access to the test-taking strategies and productivity course. You'll get a study schedule as well. Watch that course before our next weekend's webinar so that you can come in prepared. Please let me know if you have any questions, but I did want to highlight this as we get started. All right, everyone. Thank you for sticking with me through that introduction. If you're ready to go ahead and get started, go ahead and type in yes into the chat box. Everybody ready to get started? All right, Donna's ready. Catherine's ready. Nicole, Noella. Hey, everyone. Thanks so much for joining me. I just want to give you a little bit of a disclaimer. We're going to be going through tons of arrow questions today. Number one, arrow questions require focus. This whole webinar requires a lot of focus because I don't want you to miss concepts. Please put away all distractions. Focus with me for the next hour and 15 minutes. I promise you it's going to be worth your time. Let's go ahead and get started. Now, before I get started, I wanted to begin with the end in mind. What inspired me to create a webinar just on arrow questions? Kind of silly, right? Well, arrow questions on the NBMEs are just rampant. I mean, you may have seen them in your practice blocks. You may have even seen them on your practice NBMEs. You'll definitely see at least 2 to 4 questions on your actual USMLE exam. And so I wanted to write the importance of arrow questions. I wanted to share this with you. Now, arrow questions allows test writers to assess your knowledge on physiologic or pathophysiologic processes. Many of the times, the arrows are going to interrelate with each other. For example, calcium interrelates with phos, which interrelates with parathyroid hormone. NBME question writers also are going to put arrow questions because it increases the breadth of content that will be tested from the USMLE exam. And I just want to pause real quick. I'm just having a quick technical difficulty. Stay tuned for just a second. All right. I hope you can all hear me. I apologize if there's going to be any interruptions. My internet actually crashed this morning, so I am just dealing with that. So sorry about the delay. Now, what I also want to tell you is that these arrow questions test relationships among variables as well. And so arrow questions are going to be very important for your upcoming exam. Now, when it comes to arrow questions, all right, I had some technical difficulties. Is everyone doing okay? All right, perfect. I am so sorry about the technical difficulties. Hopefully we don't have any more interruptions. Sorry about that. All right, going back to this, hang with me here. We were talking about arrow questions. Now, how do we tackle arrow questions? This is key. What we're going to do is go through a test-taking strategy. Now, with arrow questions, I always say when you get an arrow question, prediction is so important because when we predict, we are going to then go in with the low-hanging fruit, the variable that you do know after you read the whole vignette. So, for example, if you suspect that there is going to be an adrenal gland tumor, you're going to say, ooh, I know that aldosterone is going to be increased, so I'm going to go in with that low-hanging fruit. And then what you'll do is you'll use that low-hanging fruit to branch out to the other variables. And this strategy, predict, low-hanging fruit, and branch out, this strategy is what we are going to use for the upcoming questions. Now, I did want to let you know from the free 120, here is an exact arrow question. So let's go through it. This is also going to give you a little bit of a preview as to what we're going to be doing next weekend. A 26-year-old man brought to the emergency department by ambulance 30 minutes after being shot in the leg. So he has some sort of trauma. The patient is unconscious and appears markedly pale. So he may be in shock, and pale means that he has anemia. So he may be bleeding out. His pulse is 120, respirations are 16, and blood pressure is 80/60. So anytime I see hypotension and tachycardia, I say the word shock. And in this patient, I'm worried about hemorrhagic shock. Now, compared with the healthy adult, which of the following is most likely seen in this patient? All right, so I know that this patient is in a fight or flight, in a stress state. So as a result, my low-hanging fruit is that I know his systemic vascular resistance is going to be very tight because he has a lot of epinephrine, norepinephrine, a lot of catecholamines. So that's my low-hanging fruit. And I know that the patient is going to have an elevated systemic vascular resistance. Now, because he's in a fight or flight state, I know RAS is going to be elevated because he's hypovolemic, and thus my capillary fluid transfer is also going to be elevated. I'm going to be absorbing more sodium, trying to increase my intravascular volume. So the absorption is what I'm going to be branching out to next. Finally, I know that he's hypotensive, hypovolemic, so my arterial baroreceptors are not going to be firing as much because there's not much carotid stretch. Why? He's bleeding out. And so the best answer here is going to be D. Pulmonary vascular resistance is high due to the fact that he has a shock state as well as increased catecholamines. So this is the way that I go with the low-hanging fruit, and then I branch out. And as you can see, we predicted and we had a working diagnosis starting in the question. All right, so overview today, what's going to be very important is going through arrow questions from specific organ systems. So from cardiology, they ask arrow questions because of hemodynamics. Respiratory, they love talking about up-down arrows for spirometry. Renal, a lot of acid-base questions that are arrow, a lot of electrolyte questions. Reproductive, what's really important here are the hormones along with endocrine. And then hematology, you're going to see a lot of arrow questions with primary hemostasis, bleeding time, platelet count, and secondary hemostasis, PT and PTT. All right, so how are we going to tackle arrow questions? One more time, prediction is key. Start with the low-hanging fruit, and then we're going to branch out. Please make sure that you have the chat box open. Intermittently, I am going to have you answer some questions. So please, again, put away distractions, stay focused with me, and we will get through it together. Let's start with our first section. That is going to be cardiology. All right. A 25-year-old female presents with dehydration after physical activity. Which of the following is most likely seen in this patient? So we have afferent carotid sinus baroreceptor firing, vagus nerve activity, and SA node activity. Go ahead and put what you think is the answer into the chat box. All right, we have a lot of great answers here. And if you said D, you're absolutely correct. Remember that this patient is going to have low carotid baroreceptor firing because she doesn't have a lot of stretch because she's dehydrated. As a result, she is going to have to increase her heart rate. And when you increase her heart rate, that means SA node activity is high. Parasympathetic activity is low because the vagus nerve releases acetylcholine. We don't want acetylcholine in this hypovolemic state. We want tachycardia, not bradycardia. So here we have the baroreceptor reflex. Remember, 9 and 10 are going to be the input for your baroreceptor reflex. What's also important for us to know is that the efferent, which is the output, that's going to be vagus and sympathetic. Remember that you always want to look at these questions with carotid stretch. So in a hypovolemic state, you are going to have low carotid stretch. That means that your afferent signal transmitted by 9 and 10 is very low. So if your afferent signal is going to be very low, then you're going to have increased sympathetic outflow, which is going to cause increased chronotropy as well as increased contractility. Very high yield for us to know. All right, going on to the next question. A 25-year-old female is rehydrated. The patient changes her position from supine to standing. Which of the following findings is most likely to be seen in this patient? So my low-hanging fruit here is when I go from supine to standing, gravity is going to pool all of the blood, all of the intravascular volume into the legs or the circulation in the lower extremities. As a result, the preload to my heart, i.e. the venous return, is going to be low. So that's going to be my low-hanging fruit here. Now, if I'm going to have a low venous return, what is going to happen to my cerebral blood flow? Well, that may drop as well. And if my cerebral blood flow is dropping, I know that I don't have much stretch at the afferent carotid baroreceptor, and thus that is going to be low. So what we notice here is that standing causes a decrease in venous return, decrease in cerebral blood flow, and a decrease in afferent carotid sinus baroreceptor activity. All right, moving forward. A healthy 30-year-old female who is 30 weeks gestational age presents with severe hypertension. She has started on nifedipine. After initiation of this therapy, which of the following is most likely seen in this patient? So just a test-taking tip. Whenever I see a pharmacological agent, I always recall the mechanism of action. Nifedipine, it's a dihydropyridine calcium channel blocker. It's going to vasodilate. So if it's going to be vasodilating, I know that my systemic vascular resistance is going to be low. So that's my low-hanging fruit. When my systemic vascular resistance is low, well, that has a reduction in afterload, okay? Because I'm vasodilating. So if I have a reduction in afterload, well, now my ejection fraction from the left ventricle is going to be high. Also, when I have vasodilation, I'm going to have, again, decreased afferent activity in the carotid baroreceptor, and thus I'm going to have a reflexive tachycardia because efferent mediated sympathetic activity is going to discharge, and now I'm going to have an efferent response that's more sympathetic related. So my heart rate is going to go up. A very important concept here. When SVR is low, you're vasodilated, watch for reflex tachycardia. That's high yield for us to know. Also, remember that a lot of your dihydropyridine calcium channel blockers cause gingival hyperplasia. They like to put that as a picture on your USMLE, and it can cause peripheral edema. And that's usually due to the fact that you've reduced SVR, you have space in between your endothelial cells, and thus you have transudative fluid that is going to leak into the interstitial space. All right, here's a question for you all. A 60-year-old male presents with shortness of breath. Physical exam shows an S3 heart sound. The patient has an enlarged cardiac silhouette on X-ray. After initiation of this therapy, which of the following findings is most likely to be seen in this patient? Your variables are LV-EDV, LV-EDP, and LV-EF. Go ahead and put your answer into the chat box, and I'd love to go for the low-hanging fruit. Go for it. Awesome. I have a lot of people putting in E, and you're absolutely correct. This patient has congestive heart failure. If they have congestive heart failure, low-hanging fruit here is the left ventricular ejection fraction. Remember that you are going to have a very dilated LV that can't push the blood forward. So your preload is going to be elevated. More blood in the heart means that you're going to have a higher left ventricular end diastolic pressure. Excellent job. Remember that these patients are going to have an S3. Why is that? Because the S3 is an early diastolic sound. They want you to know that on the USMLE. It kind of sounds like Kentucky, Kentucky. It's called an S3 gallop, and it represents the atria filling into a very dilated LV. Excellent. All right, I'm going to go ahead and do this one. A 60-year-old male presents with shortness of breath. Physical exam shows S3 heart sound. The patient has an enlarged cardiac silhouette on chest X-ray. This vignette sounds very familiar. Which of the following findings is most likely to be seen in this patient? So I know that in cardiac failure, my LV backs up into the LA, which backs up into the pulmonary veins and then the pulmonary capillaries. The reason why I have crackles is because I have elevated pulmonary capillary hydrostatic pressure, and that is causing transudative fluid to flood the alveoli, and that's why I get shortness of breath, paroxysmal nocturnal dyspnea, crackles on exam. Now, because I have a lot of fluid in that interstitium, my interstitial hydrostatic pressure is also going to be very high. And if I'm going to have a lot of fluid at the pulmonary capillary interface, I'm going to increase fluid here. All of the proteins that are here in the interstitium space, all of those proteins are going to get very diluted because I have so much fluid and transudative edema. That's why my pulmonary interstitial oncotic pressure is going to be very low. So pulmonary venous congestion is a very important concept in a patient who has systolic heart failure. This is going to be a schematic which talks a little bit about the Frank-Starling forces across a capillary bed. What I do want to really emphasize is that the primary driver for filtration, which is going to be synonymous in the glomerulus as well as in the microcirculation, filtration is getting things from the intravascular space out into the tissue space. The primary pressure that is the driver for that is your pulmonary capillary hydrostatic pressure. And due to venous congestion, we have an increased pulmonary capillary hydrostatic pressure. The primary driver for reabsorption in your glomerulus as well as in your microcirculation for reabsorption, which represents the fluid that is going to go from the tissue space back into the blood vessel, reabsorption, that is going to be the capillary oncotic pressure. Very high yield for us to know. The capillary oncotic pressure is going to pull that fluid back in. That is why USMLE test writers love to go for nephrotic syndrome, low oncotic pressure, you get a lot of edema. All right, I'm going to go through this one with you. A teenager was ice skating on a frozen lake and is suddenly submerged in cold water. Brr. Which of the following findings is most likely to be seen? Well, when I'm in cold water, I know that my core body temperature is going to drop and all of the blood needs to shunt centrally in order for me to warm up my core body temperature. So I know that my central blood volume is going to be very high as all the blood shunts towards this core portion. When I have a lot of central blood volume that is going to go into my central venous circulation, my atria are going to stretch. And if my atria are going to stretch, I know that my ANP release is going to be very high. Now, ANP stands for atrial natriuretic peptide. It makes you pee. It is complementary to anti-P hormone, which is ADH. ANP, ADH are opposites. And thus, my ADH release is going to be low because I have more natriuresis. So I do want you all to kind of recognize this mechanism. I did put a balance beam here because I want you to recognize that the RAS system as well as ADH are going to be balanced or inversely proportional to ANP. Remember that when patients, for example, are going to have a renin or specifically an aldosterone secreting tumor, that aldosterone secreting tumor is going to cause you to have upregulation of ENaC channels in the collecting duct. That brings in sodium. And with that comes water. That expands your intravascular space. Thus, you get increased venous return back to your heart. If you get increased venous return back to your heart, you get stretch of the atria. What does the stretch of the atria do? Well, it is going to increase ANP, high venous return, high atrial stretch, increased ANP, and subsequently, you're going to have natriuresis. And remember, if ANP is elevated, your ADH is going to be low. Let's continue on with the next question. This one's your turn. A 2-year-old female with history of a VSD presents to the pediatric cardiac ICU after a VSD repair. Compared to prior, which of the following is most likely to be seen post-repair? LV pressure, RV pressure, LA pressure are your variables. Go ahead and put into the chat box what you think the answer is. All right. This is going to be a relatively tough question. Getting a lot of different answers. If you said B, you're absolutely correct. Let's go through the explanation here. If this is the heart, after the VSD repair, and I did put a little bit of a patch right on where they would patch up the VSD, remember that you have less shunting of blood from LV to RV. As a result, you hope that your RV pressures are going to go down. Remember, if you have less shunting, LV to RV, that means that you're going to have less blood in the pulmonary circulation and then less blood coming in via the pulmonary veins into the LA. So your LA pressures are going to go down. You have less blood going LV, RV, PA, pulmonary capillaries, pulmonary vein, and LA. You have less blood going into the LA now because you have a patch. When you are going to put that patch, you are going to have a now closed circuit with the left ventricle, and thus your LV pressure is going to go elevated. And so that's why the correct answer is going to be B. Remember that when it comes to a VSD, typically it's due to the membranous portion of the interventricular septum that is going to fail to develop. The membranous, which is going to be a posterior growth from your endocardial cushions. All right. A 12-year-old female presents with tachypnea, so increased work of breathing. She has an S2 heart sound that does not change with the respiratory cycle. This is what they call the fixed S2. Very important for you to know. Which of the following findings is most likely to be seen in this patient? So I do think that this patient has a ASD. Typically ASDs, unless you have Eisenmangers, ASDs are left to right. So if I'm going to have left to right shunting, My low-hanging fruit is my RA pressure because blood is going LA, RA. Now, what I do know is that the LA blood, left atrium blood, is very red. That's going to mix with the blue blood. So my right ventricular SaO2, that's going to be increased because now I have red blood mixing with blue blood, LA, red blood, RA, blue blood. Now I have a mixed blood in the RA that is coming down into the right ventricle. And from right ventricle, you are going to go into the pulmonary artery. So my best answer here is going to be E. Please note that in a left to right shunt, you get a step up in your saturations. USMLE loves to go for that for both ASDs and VSDs. Left to right, red blood going into the blue circulation. Ladies and gentlemen, we have just finished cardiology. I hope you learned a lot. Go ahead and type in yes if you're pumped to get started with respiratory. All right. You guys are doing so awesome. I'm proud of you. Let's go ahead and go through the respiratory system arrow questions. A 50-year-old male with history of severe COPD presents with health maintenance. Which of the following findings is most likely to be seen in this patient? COPD, obstructive lung disease. They are going to have air trapping. If they're going to have air trapping, my low-hanging fruit, I know that I can't get that CO2 out. If I can't get that CO2 out, well, I'm going to be having a very high CO2. If I have a very high CO2, chronically, I have a chronic respiratory acidosis. Thus, my pH is going to be low. And over time, my kidneys are going to try to buffer the chronic respiratory acidosis by increasing the reabsorption of bicarbonate. So this patient has a chronic respiratory acidosis. Remember that patients with COPD or any obstructive lung disease, they're going to have air trapping. Air trapping causes you to have poor ventilation. That means that your CO2 builds up. If your CO2 is high and the CO2 builds up, that is basically going to mean that you're going to have a chronic respiratory acidosis, which is represented by a low pH and a high CO2. What do your kidneys do? Well, after about 24 hours, kidneys start reabsorbing the bicarb to buffer you back. This one is your guys' question. Let's go through it together. 15-year-old athlete is recovering from ACL surgery. He is given IV morphine. His respiratory rate is 7. The patient has crackles in bilateral bases. Which of the following is most likely to be seen in this patient? Go ahead and put in what you think the answer is. pH, AA gradient, and the CO2 are your variables. Wonderful. I'm getting a lot of A's, and you're absolutely correct. Because this patient was given a mu opioid agonist, you notice that the patient started having hypoventilation. They could also put pinpoint pupils, but hypoventilation and being postoperatively can give you atelectasis, and this can be represented by crackles in the bilateral bases as the small alveoli are trying to pop open a little bit. This is an acute respiratory acidosis. In an acute respiratory acidosis, most likely it's going to be due, especially in this question, to hypoventilation. My CO2 is going to be high, my pH is going to be low, and remember that hypoventilation is a cause of hypoxemia, which is low P little AO2, that does not change your AA gradient. If I asked you what's another cause of hypoxemia that does not change your AA gradient, high altitude is the correct answer. Hypoxemia, high altitude, hypoventilation, hypoventilation, high altitude. Those are your two causes of non-AA gradient increasing hypoxemia. When we think about hypoxemia, that means you have a low P little AO2. Remember, this also affects your hemoglobin oxygen dissociation curve. We typically talk about the alveolar arterial gradient. Basically, the job of the lung is to take P big AO2 and turn it into P little AO2. And any obstruction to this process will elevate your AA gradient. If you have issues with the V, which is going to be the alveoli, or if you have issues with the Q, what we call VQ mismatch as a broad term, you will have hypoxemia, low P little AO2, and because it's messing with the alveolar capillary interface, VQ mismatch is one of the most common causes of hypoxemia that elevates your AA gradient. You may have a patient on your USMLE that right here in green has fibrosis at the interstitium between your alveoli and your capillary. This diffusion defect, again, hypoxemia with an elevated AA gradient. You may have a situation where you have a patient who has tetralogy of Fallot, in which they have blue blood that completely bypasses the lungs thanks to the VSD, and that blue blood goes into the left-sided circulation, bypassing the lungs, and thus a right to left shunt is going to be an example of hypoxemia. And because you're bypassing the pulmonary capillary interface, your AA gradient is going to be elevated. So elevated AA gradient, anything that messes with pulmonary capillary interface. Very good. Let's keep going. A 22-year-old female has been diagnosed with nodular sclerosing Hodgkin's lymphoma. For menstrual control, she takes oral contraceptive pills. 2 weeks after, she has acute onset of tachycardia and tachypnea. Which of the following findings is most likely to be seen in this patient? Anytime I see a onc patient, I think of a hypercoagulable state. And with the OCPs, I also am going to be worried about a hypercoagulable state. Anytime on the USMLE you see acute onset of tachycardia, tachypnea, pay your respects to a pulmonary embolism. If you have a pulmonary embolism, you have now a V that is still there, but the Q is messed up. This is what we call a pathologic dead space, because your pulmonary capillary is obstructed and this alveoli thus is dead. What I know now is my AA gradient is actually going to be elevated in a patient who has VQ mismatch. And remember that pathological dead space is an extreme of VQ mismatch where you don't have a Q, and because your V to Q ratio now approaches infinity, your VQ ratio is going to be high. And because she has tachypnea, very important, always correlate that vital sign with the CO2, because increased respiratory rate means increased minute ventilation, means that you're breathing out CO2. So typically patients with an acute pulmonary embolism have an acute respiratory alkalosis. This is a very good question. Please make sure you continue to revisit pulmonary physiology. All right, this is a question for you all. An 85-year-old female undergoes a study on aging compared to an adolescent, which of the following is most likely seen in this patient? You have FEV1, FVC, and the ratio of FEV1 to FVC. What do you think is the best answer here? All right, wonderful. Well, whenever you're aging, you're going to have a kind of like a obstructive lung disease type of pattern. Your FEV1 is going to be low. Your FEV1 to FVC ratio is also going to be low, kind of again, like an obstructive lung pattern. So aging and the lungs for the USMLE, ready, set, go. As you age, you start having low chest wall compliance. That means your chest wall doesn't go out as much. Think of it as all of the cartilage here starts calcifying a little bit. Your lung compliance goes up. If your lung compliance goes up, you're going to have a nice floppy lung, i.e., you can fill it very easily and you have a higher residual volume. What's important though, is you can't really get the air out. That's why your FEV1, your FVC, and the ratio is going to go down. Remember that your total lung capacity is actually going to be normal, okay? Your total lung capacity is actually going to be normal. And that's extremely, extremely important for us to note. Why is your total lung capacity going to be normal? Well, it's because you now have a balance between, and I apologize for this, you now have a decreased chest wall compliance, but you have increased lung compliance. So now you have a balance out of your chest wall and the lungs, and thus your total lung capacity is going to be normal. So it's unchanged because the decreased chest wall compliance balances the increased lung compliance that you see, okay? And that's why your total lung capacity is normal. All right, let's keep going. An X26-week preemie presents to the neonatal ICU with respiratory failure. So I know she's a preemie. Which of the following is most likely to be seen in this patient? All right. When I have a premature baby, I know that my surfactant is down. If my surfactant is down, I know that I'm going to have a high surface tension on the alveoli, and the alveoli are going to be collapsing. Well, if my alveoli are going to be collapsing, I know that my elastic recoil is going to be very high because they're going to be collapsing down. They're recoiling down, and I won't be able to fill the alveoli because I need surfactant to even open up that alveoli. So my pulmonary compliance is going to be very low. Remember that surfactant is made up primarily of lecithin, which is phosphatidylcholine. So my sphingomyelin is actually going to be high because the surfactant is very lecithin oriented. Surfactant is very phosphatidylcholine. Surfactant is made from the lamellar bodies if they ask you a histo question. This is neonatal ARDS. They could give you a chest x-ray. Typically what they call this is a ground glass chest opacities, which represents the atelectasis of the small alveoli, and then all the air gets pushed centrally. So it is called ground glass appearance with air bronchograms. And remember that in neonatal ARDS, you do not have any mature surfactant. What is mature surfactant? Remember that it is when you have a lecithin to sphingomyelin ratio that is greater than 2 to 2.4. Lecithin is a major component of surfactant, and it's diphosphatidylcholine. All right, everyone, we're going to be going on to endocrine. Are you guys learning something? Go ahead and type in yes into the chat box. Excellent. Hey, everyone, thanks for paying attention. Stick with me here. Let's go on to endocrine. A patient presents with refractory inflammatory bowel disease, started on prednisone. At 3-month follow-up, The patient has a streaking rash on his abdomen, increased abdominal girth, a full face with a ruddy complexion. So these are all signs of Cushingoid. He is hyperglycemic. Which of the following is most likely to be seen? So I know that this patient has exogenous steroids. If they have exogenous steroids, my endogenous hypothalamic pituitary axis as it relates to cortisol is going to be very low. I know that I'm going to now be in a very catabolic state. If I'm in a very catabolic state, my muscle is breaking down. Remember, they have muscle wasting, and thus my plasma amino acids most likely are also going to be high. So the key here is for us to note that when you take exogenous prednisone, you shut down your endogenous hypothalamic pituitary axis. That's really important because you could get a test question on the USMLE in which they have a patient who has adrenal insufficiency secondary to the prednisone, and they undergo some stressor. And that stressor could be a surgery, that stressor could be an illness, and subsequently, afterwards, they turn the vignette into a hypotension, tachycardia, hyponatremia type of vignette. And that vignette represents an acute adrenal crisis due to the fact that your chronically suppressed hypothalamic pituitary axis cannot handle the stress from the surgery or the illness. All right, this is a question for you all. A patient has an incidental adrenal mass and physical exam features of Cushing's syndrome. He is on no medications. Which of the following is most likely to be seen in this patient? Your variables, ACTH, cortisol, and urine potassium. What do you think the answer is here? All right. Well, remember that the patient has an incidental adrenal mass and signs of Cushing's syndrome. So this really is related to a tumor from the fasciculata, and your cortisol is going to be high. That's going to negatively feed back and shut down your ACTH. And what's really interesting is that in these high cortisol states, high glucocorticoid states, you may have permissive effect on your mineralocorticoid receptor, and thus you will potassium waste, just like having aldosterone around, and your urine potassium is going to be very high, and that's why the answer is going to be A. So what we just talked about is a very important test-taking strategy for endocrine. When cortisol is going to be high, negative feedback, ACTH is going to be low. I do want to review aldosterone. Remember, aldosterone is going to be derived from the RAS system. Where does angiotensin 2 act? Well, it's going to increase aldosterone at the zona glomerulosa. And we note here that aldosterone has 3 effects, very important. Brings in sodium and makes you pee out potassium and makes you pee out hydrogen ions. Please remember the 3 effects of aldosterone. Extremely important because there are probably 4 to 5 to 6 questions on NBMEs and on your real exam that play with this aldosterone concept, either from an electrolyte standpoint, acid base, or hypovolemia, hypervolemia standpoint. A college student presents in shock to the pediatric ICU. He has a widespread petechial purpural rash. He had a prodrome of fever and neck stiffness. So what I'm worried about here is going to be Neisseria meningitidis. And If he is in shock, what does Neisseria meningitidis do? Well, Neisseria meningitidis causes Waterhouse Friderichsen syndrome. That is basically acute adrenal insufficiency. As a result, I know my cortisol is shot. It's out of here. My whole glomerulosa fasciculata reticularis, it's out. Thus, I know my cortisol is going to be very low. If I don't have any aldosterone, I can't pee out H+. If I can't pee out H+, I become very acidotic. My pH drops because I don't have aldosterone. And remember that if I don't have aldosterone, I'm going to be wasting sodium in the urine, and thus I'm going to be hyponatremic. So an acute adrenal insufficiency, no cortisol, no aldosterone. With no aldosterone, you get a non-anion gap metabolic acidosis, and you get hyponatremia. Very important for you to know. Waterhouse-Friderichsen syndrome, they love to give you this picture, hemorrhage of the adrenal glands on your gross pathology. All right, this is your question, shifting gears a little bit into thyroid. A 30-year-old male presents with anxiety, weight loss, tremulousness. He is feeling hot constantly. His thyroid is tender. No drugs. Tox screen is negative. This is what I call a pertinent negative in an exam question. You'll learn about that as you go through my courses. Which of the following is most likely seen in this patient? You have TSH, T4, iodine uptake scan. What do you all think is the best answer here? Go ahead and put it in the chat. And I do hope you all are going for that low-hanging fruit because that's so important. All right. Wonderful. And I want everybody to participate. Let's go through this. This patient is most likely going to have a thyroiditis. And I know that by this vignette, his T4 is going to be high. If his T4 is high, negative feedback, my TSH is going to be low. And this is the important portion of the iodine uptake scan. When the thyroid is inflamed, it does not want to take up anything. It's like when the thyroid is sick, when you're sick at home, do you want to talk to anybody? No, your uptake is going to be low. Very high yield. Let's go into a very important algorithm. Please recognize that you need to see the signs in a vignette of hyperthyroid. Tachycardia, tremulousness. They may have exophthalmos if you're thinking about Graves' disease. Whenever you suspect hyperthyroidism, you're going to get a TSH and T4. And if you have a T4 that's high and a TSH that's low, you've already made your diagnosis that that's primary hyperthyroidism because it's coming from the thyroid gland. Now, say that you have these prosympathetic symptoms. Well, if your TSH and T4 are normal, the USMLE may be going down the route of a psych question or maybe even a pheochromocytoma. Get your HVA and VMA. Now, when you have primary hyperparathyroidism, it's not parathyroidism, excuse me. When you have primary hyperthyroidism, okay, we'll get to parathyroid soon. When you have primary hyperthyroidism, you're going to be doing an uptake scan. And if your uptake scan shows a low uptake in the setting of hyperthyroid, well, you're going to say, this must be either a thyroiditis, ouch, 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 thyroiditis, or you have shut down the thyroid axis because you're doing exogenous thyroid hormone. So low uptake when there's thyroid atrophy and when there's a thyroiditis. If you have single hot uptake or you have multiple hot uptakes, well, then you're thinking that this is an autonomous secreting multinodular or adenoma. And then finally, if you have a diffuse uptake in your uptake scan, and again, your patient is hyperthyroid, they may have now exophthalmos here, which is pathognomonic. That is Graves' disease. So again, diffuse uptake on your thyroid uptake scan, that is Graves' disease. So the general concept that I do want to note is that when the thyroid is inflamed, i.e. you have a thyroiditis that could be postpartum, that could be due to after an upper respiratory tract infection, tender thyroid, there will be no uptake. All right, very important. Let's solidify this concept. I'm going to ask you to go ahead and answer this question. A 42-year-old female nurse presents with anxiety, weight loss, tremulousness. She is noted to have injected IV T4 in efforts to lose weight. Which of the following is most likely to be seen in this patient? What do you think is the best answer here? Wonderful. Well, if you're thinking it is A, you're absolutely correct. Remember, IVT4 is going to be injected. As a result, your TSH is going to be low. You're going to be shutting down your endogenous thyroid gland. If you're going to be shutting that down, your uptake scan is going to be low. And remember, we talked about this right here where we talked about factitious. Your uptake scan is going to be low. All right. Very good. Let's go ahead and go through this question. A patient is in the ICU for acute COVID pneumonia. He has acute respiratory distress syndrome. He is on the ventilator. He is in cardiogenic shock and a continuous epinephrine infusion. He's pretty sick. Which of the following is most likely to be seen in this patient? Well, when you become sick, your body goes into a very protective mode. It doesn't want to expend too much energy. And so what ends up happening is you start getting more shunting of the thyroid hormone into an inactive form, which is your reverse T3. And if your reverse T3 is going to be made more, obviously the value is going to be high. Now, this diagnosis is known as Euthyroid 6 syndrome, in which you have a patient who is very, very ill, and your reverse T3 concentration is going to be elevated, but the rest of your thyroid profile is going to be normal. So let's go into this in a little bit more detail. In Euthyroid 6 syndrome, you have a relatively normal T4 and you have a relatively normal TSH as well. Remember, your body in the stress state is going to try to conserve your energy. And thus, you're going to have decreased conversion from T4 to T3, but your inactive form, that reverse T3, is going to be elevated. And that's the hallmark that the USMLE really likes to go for. Next question. A 30-year-old female is pregnant. She has no complications or no family history of autoimmune disease. Prior to the pregnancy, she was on oral contraceptive pills. So pregnant and oral contraceptive pills, a crowd favorite. What kind of thyroid profile would this patient have? Well, what I do know is that in pregnancy and OCP, high estrogen states that increases my thyroid binding globulin. My total T4 levels are going to go up if my thyroid binding globulin is going to go up. Very important. I know now that my total T4 is going to be very high. In this state, the free fraction is actually going to be normal. The free fraction is going to be normal. And it is that free fraction that determines feedback. Well, remember that if I have high TBG, high total T4, if I look at my ratio, my denominator is going to be very high, and thus the ratio is going to be very low. So the key summary points: estrogen increases liver thyroid binding globulin. Thyroid binding globulin increase downstream causes an increase in total T4, doesn't really affect your free. Why? Your free T4 is normal as the TSH transiently regulates the T4 back to a normal level. The free T4 is going to just get back to a normal level because there's a transient bump in TSH and it is the only T4 total that is going to be elevated. Super important. And again, high estrogen states on your vignettes, OCPs, as well as pregnancy. A child presents with seizures. He is found to have a low ionized calcium and a murmur is heard. A genetic etiology is suspected. I want you all to put in the chat, what do you think is the genetic etiology that is occurring? Please go ahead and put it in the chat box. Wonderful. And I'm really proud of each of you for paying attention. Thank you. Really appreciate it. Wonderful. So I know that I have DiGeorge syndrome, which is 22q11 deletion, a bad third and fourth pharyngeal pouch. And thus, I know that I don't have good parathyroid glands. If I don't have good parathyroid glands, well, my parathyroid hormone is not going to be released. As a result, if I don't have parathyroid hormone, I'm going to have low calcium and parathyroid hormone, as we will learn soon. PTH helps you phosphate trashing hormone. And if I can't trash my phosphate is going to be high. So this is called primary hypoparathyroidism. What we have to notice here is that PTH is going to have the effect on the bone and the kidney. Let's start with the bone. PTH is going to increase bone resorption. That means bone is going to break down. It does that by binding to the osteoblast to form rank ligand that is going to then bind onto the rank receptor on the osteoclast. And remember, osteoclasts are macrophage lineage, and those osteoclasts, once the rank ligand binds, that's going to start increasing the activity of the osteoclast, and you're going to break down bone. In the kidney, PTH activates 1-alpha hydroxylase. You get more conversion to active vitamin D. Very important for us to know. But PTH increases calcium reabsorption. This is primarily going to be in the distal convoluted tubule via upregulation of calbindin. In the proximal convoluted tubule, though, PTH phosphate trashes. And I just want you to really know this, that PTH decreases phosphate reabsorption. It trashes your phosphate. PTH, phosphate trashing hormone. You do need normal kidney function, though, to phosphate trash. Please remember, normal kidney function needed for phosphate trashing. What does 125 vitamin D do? Well, 125 vitamin D increases calcium and phos reabsorption from the intestines. In the intestines, 125 vitamin D increases calcium and phos absorption. And so if we did a quick little compare and contrast here, PTH normally increases calcium, decreases phos. PTH does make active 125 vitamin D, but the active 125 vitamin D increases calcium and increases phos. And so that's a little bit of the difference here to keep in mind. All right, a child presents for evaluation for dialysis due to chronic kidney disease secondary to focal segmental glomerulosclerosis, which is a nephrotic syndrome. Which of the following is most likely to be seen in this patient? Well, if I have kidney failure, I know that I don't have good PTH regulation. In fact, in kidney failure, I won't be able to phosphate trash. If I won't be able to phosphate trash, well, my PO4 is going to be high. Will I be able to reabsorb all that calcium? The answer is no. And because I'm hypocalcemic and I have kidney failure, bam, I have reactive increase of parathyroid hormone. In kidney failure, they love for you to know that the phosphate is high. Because in kidney failure, you cannot phosphate trash. You can't pee out the phosphate at the proximal convoluted tubule. The patient who is in renal failure is now a teenager and continues to have chronic renal failure. Which of the following would most likely support tertiary hyperparathyroidism? So tertiary hyperparathyroidism is going to be a continuation of secondary hyperparathyroidism. Most common cause of secondary hyperparathyroidism, kidney failure. And remember that when you have longstanding secondary hyperparathyroidism, usually due to longstanding kidney disease, you go into a new homeostasis. Your body says, wow, I have been really having a high PTH forever and ever and ever and ever. So you know what? I'm just going to go to a new homeostasis. And it is in that new homeostasis that you still have a very high phos, but your calcium now ends up switching from a low to a high. So anytime on the USMLE, you have somebody with chronic kidney disease who initially had secondary hyperparathyroidism, and now, bam, the calcium is high. Watch for tertiary hyperparathyroidism. So tertiary hyperparathyroidism, the way that I like to think about it is that you have a new homeostasis. PTH chronically is elevated, and now you are been chewing away your bone to the point where your calcium is now going to be elevated. It switches from hypo to hypercalcemia. All right. Why don't you all go through this question? A 12-year-old male presents with short legs on X-ray. He is also noted to have shortened fourth and fifth digits on bilateral hands. Which of the following is most likely to be seen in this patient? And yes, in the chat box, that's why we use phosphate binders. Yes, sevelamer is going to be the phosphate binder. Very good. Which of the following is most likely seen in this patient? What do you all think is the answer here? Proud of everybody paying attention. Excellent. All right. Now, this is Albright hereditary osteodystrophy. It's also known as pseudo hypoparathyroidism. What we have to note here is that in pseudo hypoparathyroidism, you have signs of hypoparathyroid. Hypoparathyroid is high PO4, and a low ionized calcium. You have signs of hypoparathyroidism, but it's pseudo. Why? Because your PTH is very elevated. This is typically due to the fact that you have a mutation in the GS receptor. The PTH is there in this case, but is resistant. There's no end organ effect. As a result, your bone gets chewed up, and you have this characteristic fourth and fifth digit shortening on your hands. So I wanted to put together Albrights for the USMLE. This is the integration portion. Remember, we just talked about Albright hereditary osteodystrophy, shortened fourth and fifth digits. That's characteristic in exam questions. It's a pseudo hypoparathyroidism. PTH is there, but it's not working. And this is due to a abnormal GS subunit. The gene is GNAS mutation. McCune-Albright syndrome, that also had Albright in it, but it's totally different. In this case, this is a tie-in with cafe au lait spots. So whenever you see cafe au lait spots, you think neurofibromatosis and McCune-Albright syndrome. And especially if they have cafe au lait spots that are diffuse, they kind of coast of Maine cafe au lait spots. They have these bone changes, which is the bony replacement with fibroblasts. That's called polyosteotic fibrous dysplasia, also known as brown tumors of the bone. And these patients have precocious puberty. So characteristically, an MSK precocious puberty, and cafe au lait spots, you got to know McCune-Albright syndrome. And again, I put all this here because Albrights were confusing when I was studying together. And this is the beauty of it. I went through this and I get to inspire the next generation of USMLE test takers. I'm very proud of you. Go ahead, guys. Let's go ahead and go through this question together. A 24-year-old female presents with erythema on the shins. She has a dry cough. Chest x-ray shows fullness in the perihilar regions. Which of the following is the most likely to be seen in this patient? Your parameters: 1-alpha hydroxylase activity, fecal calcium, 24-25, vitamin D. What do you think is the answer? Stick with me here. Great. Getting some really good answers here. Please remember that the diagnosis here with the hilar lymphadenopathy is sarcoid. You have non-caseating granulomas in sarcoidosis. That is going to have endogenous 1-alpha hydroxylase activity. Remember, the granulomas have high 1-alpha hydroxylase activity. That means that your 24-25 vitamin D, which is a storage form, is going to get converted into 125 vitamin D. If you have more conversion to 125 vitamin D, your 24-25 vitamin D is going to be low. And remember that if you have a lot of 125 vitamin D, you're going to be pulling all that calcium from the gut into the blood. So your fecal calcium is going to be low. And I'm sorry about the typo here, but the correct answer is going to be C. Very high yield for us to know that your fecal calcium is going to be low because you're going to be pulling all of that calcium from the gut into the blood due to increased 125 vitamin D. Next question. A child with cystic fibrosis comes for annual health screening. He has steatorrhea. He has been non-compliant with therapy. If you have steatorrhea, you know you have fat malabsorption. And in this case, vitamin D may be deficient. If you don't have good vitamin D, what's going to happen? Well, if you don't have good vitamin D, you're going to have not much calcium and phos reabsorption at all. And thus, the answer is going to be C. No 125 vitamin D, which again, in kids, it's going to be known as rickets. No 125 vitamin D, you get low calcium, low phos, and subsequently, because of the low calcium, you have a high PTH. Remember, hypocalcemia is a very key driver for PTH secretion. So vitamin D metabolism 101 here. Sun emits the UVB light. Just as a biochemistry tie-in, they love to test thymidine dimers with UVB light. That's an NBME question. Sun emits UVB light. The cholesterol in your skin becomes cholecalciferol. I'm gonna soak up the sun. So you now have pre-vitamin D that then goes into your liver, and that cholecalciferol becomes a storage form, 24-25 vitamin D. That 25 vitamin D, what's going to happen here is your kidney, due to effect of parathyroid hormone and stimulation of 1-alpha hydroxylase, you're going to have 25 vitamin D to 125 vitamin D. And that is going to reabsorb calcium and phos within your gut. Let's take it one step further. When you have endochondral ossification, that calcium and phos that's reabsorbed, everyone, that turns your osteoid immature matrix and turns it into hydroxyapatite crystals that are made up of calcium and phos. Very important for us to know. And I'm just taking that concept one step further. A 77-year-old male presents with headache and Bell's palsy. CT shows occipital enhancement with thickening of the cortical bone. Thickening of the bone in an elderly patient. You're worried about Paget's disease, especially because the headache is due to the fact that you have increased intracranial pressure and you have compression of the cranial nerve. So these patients can have hearing loss, and they can even have Bell's palsy, cranial 7 and 8, because as the foramina keep thickening, and getting smaller and smaller. And remember that in this Paget's disease of the bone, you have an isolated increase. You have an isolated increase all the time in Paget's disease of the bone, isolated increase in alkaline phosphatase, which is a marker for, number one, bone, as it relates to Paget's disease of the bone, very important. And number two, alkaline phosphatase. When that's elevated, you should also be thinking liver issues as well. Paget's disease of the bone, it's a lot of bony turnover. It's an imbalance between osteoblasts and osteoclasts. And in Paget's disease of the bone, you have an isolated alk phos increase. Just like how I did for Albright, I want to integrate all of the Paget's disease that you need to know. Here's a popular guy. Paget's disease of the bone. Old man, increasing hat size, sole increase in alk phos. Paget's disease of the breast. Eczema on the breast with nipple ulceration. Remember, this represents breast ductal carcinoma in situ that's traveled up to the nipple. Paget's disease of the vulva. Whenever you see Paget's disease of the vulva, your differential, just like Pathoma says, is melanoma. However, Paget's disease of the vulva is PAS positive, keratin positive, and because it's not melanoma, it is S100 negative. They typically put signs of inflammation at the vulva. So remember that the vulvar skin may be erythematous and pruritic. All right, this is your question. A 58-year-old female presents for health maintenance. She has a Z-score greater than 2.5 on DEXA bone scan. She is in menopause. Which of the following is most likely to be seen in this patient? What do you think is the answer? Your parameters are alk phos, iCal, and phosphate. Wonderful. So if you're worried about osteoporosis, remember osteoporosis, it's a silent disease. And if it's a silent disease, remember, as you age, as you go into menopause, you can have the likelihood of going into having some osteoporosis. It's a decrease in trabecular bone with no changes in calcium phos or alk phos. Okay, so it's normal all around. And that's why it's a silent disease. Speaking of menopause, reproductive. Ladies and gentlemen, we only have 2 more sections left. I know this is a little bit of a longer webinar, but stick with me. This is important, and I want you to review this webinar after we're done as well. Reproductive, here we go. A 58-year-old female presents with health maintenance. She has irregular menses, hot flashes. Her thyroid tests are normal, pertinent negatives. Which of the following is most likely to be seen? So, given her age and given the fact that she has hot flashes, etc., we're worried about menopause. My low-hanging fruit with menopause, your estrogen is most likely going to be low. You're also going to have gonadal atrophy. Your gonads are not going to be working as well. And thus, your FSH is going to be high. Your follicles are not going to be working as well. So FSH, follicle stimulating hormone, is going to be high. And remember that as a result of your granulosa cells not working as well, your inhibin, which is the feedback for FSH, that's going to be low. And that's why high FSH really represents menopause. And the way that I think of it is I say F menopause. All right. So just real quick, you have LH and FSH. In the female, at the ovary level, you're going to have your theca interna cells. You're going to have your granulosa cells. LH stimulates theca interna to secrete testosterone. That testosterone goes across the extracellular matrix into the granulosa cell. It's a steroid hormone, so it crosses the lipid bilayer. Granulosa cells, really important for us to know, have the aromatase, and FSH actually activates the aromatase to turn testosterone into estradiol. And it is this granulosa cell that secretes inhibin. that then is going to normally shut down FSH. In our case of menopause, no good theca interna, no good granulosa, and thus your FSH is going to rise with a low estrogen. A 16-year-old female athlete presents for health maintenance. She has irregular menses and a BMI that's 18. A foot X-ray shows small, thin fractures at the cortical margin. This is representative of a stress fracture, and any sort of menstrual abnormalities in a patient who's maybe having increased physical activity and not as much weight on them, you're going to have shutdown of your hypothalamic pituitary axis. That shutdown of your hypothalamic pituitary axis is going to be represented by a low GnRH, a low FSH, and a low estrogen. And remember, because you don't have estrogen, your bones are going to be very weak, very high yield for us to know that your bone is going to be very weak when you don't have good estrogen. All right, why don't we go ahead and have you all answer this question. A patient with anorexia is placed in an intensive nutritional rehabilitation program. The patient is noted to have multiple bouts of hypoglycemia. Refeeding syndrome is suspected. What do you think is going to happen? And your variables are serum K, serum phos, and glycolysis activity. What do you think is the best answer here? Wonderful. So in refeeding syndrome, you are giving back the food. If you're giving back the food, the body is going to say, whoa, I'm now going to start secreting more insulin. I need to start making more ATP because I was in a chronically malnourished state. So what's going to happen? All of your potassium, because of the high amount of insulin and the beta agonist activity that comes with the insulin, all of your potassium is actually going to shift inward. So your serum potassium is going to be low. Because you need to make more ATP, you're going to have a low phos. And that's actually the characteristic feature in refeeding syndrome. And remember, you have a lot of food. So your cell is going to be doing a lot of glycolysis. It's going to be breaking down the sugar. And just to relate the phos a little bit more, remember that you're going to have increased hexokinase activity. Well, if you have increased hexokinase activity, what is it going to need to kinase? It's going to need the phos. So no wonder your phos being low is really important for refeeding syndrome. A female presents with irregular periods. She has had a 30-pound weight gain for 3 years. Exam shows hair at the upper lip, so signs of high testosterone, and ultrasound of the ovary is shown. This is a radiographic image of the ovaries. See how systematic I am? Number 3, you notice that these are these cysts that are scattered around the ovary. Diagnosis is going to be PCOS. In PCOS, you have high testosterone. That's my low-hanging fruit. And that's because you have an elevated LH. For some reason or the other, you have an elevated LH in PCOS. In PCOS, if you have an elevated LH, your LH to FSH ratio is also going to be high. And thus, watch for signs of hypertestosteronism and irregular menses. That's your illness script for PCOS. All right, I want you all to get active in this one. A 15-year-old football player presents with increased acne. Exam shows increased muscle bulk, so signs of high testosterone states. He has started a new supplement to build muscle. Which of the following is most likely seen? You have LH, gonadal size, and GnRH. And again, I want that low-hanging fruit. That's going to be super important. Wonderful. Remember, exogenous testosterone is actually going to shut down your hypothalamic pituitary axis, and it's going to cause you to have gonadal atrophy. Okay. So exogenous testosterone, just like exogenous thyroid hormone, it shuts down your endogenous endocrine organs. A 25-year-old female is 40 weeks pregnant. Congrats. She undergoes induction of labor. Oxytocin, which is secreted from the posterior pituitary, but we're giving it through an IV to augment labor. Oxytocin is administered. Which of the following is most likely seen when oxytocin is up in the body? Well, oxytocin contracts the uterus. So just like my haircut, new haircut, it acts via GQ. GQ means that you have excessive IP3 and DAG activity, because that's all G protein coupled receptor Q, all about increased intracellular calcium. Remember, DAG activates protein kinase C, and GS activity is relatively normal. So the best answer here is going to be A. Ladies and gentlemen, we have just a little bit of renal left, just a little bit of hematology, and then we are done. I ask for 10 more minutes of your time, please. This is a high-yield webinar. I hope that you all are learning. If you all are learning and enjoying all of these questions, go ahead and type in yes into the chat box. I've really tried my best to put in these really important NBME questions. All right, you all are doing so well. Still over 100 people joining. Let's do it. We're almost there. Renal, coming at you next. Here we go. A patient is diagnosed with a tumor of the adrenal glomerulosa. Okay, glomerulosa fasciculata reticulata. Aldosterone is elevated. If I have a high amount of aldosterone, I'm going to be bringing in more sodium, and I'm going to be peeing out potassium and hydrogen ions. So let's go through this. If I have a tumor of the adrenal glomerulosa, high aldosterone, I'm going to pee out a lot of potassium. If I pee out a lot of potassium, my serum potassium is going to be low. I'm going to also pee out a lot of hydrogen ions. If I'm peeing out a lot of hydrogen ions, my H+ is low. But because I'm bringing in more sodium because of high aldosterone, my urine sodium, again, upregulating ENaC channel. So from the pee, I'm pulling in a lot of sodium. My urine sodium is going to fall. Why don't you all help me with this one? A patient presents with weakness, hyperpigmentation, and hypotension. Which of the following is most likely to be seen? pH, serum sodium, and urinary potassium are going to be your variables. What do you think is the best answer here? All right, wonderful. We have a lot of good answers. So remember that this patient is going to be having primary adrenal insufficiency. And that's very characteristic because she has salt wasting. And as a result, she has hypotension as well. Okay. So if you don't have a lot of aldosterone and you're salt wasting, you are going to have a very low serum sodium. If you don't have a lot of aldosterone, you're not going to be peeing out a lot of potassium. Again, aldosterone does three things: it brings in sodium, makes you pee out potassium and hydrogen ions. So you're going to be not having much urinary potassium. If you're not going to have much urinary potassium, and subsequently, you're also not going to have a lot of aldosterone. Remember, low aldosterone states, that means that you lose salt and you retain K, thus your urinary K is low, and you retain H+. you retain H+, your pH, again, acidosis, non-anion gap, metabolic acidosis in your adrenal insufficiency. Hyperpigmentation, this is seen in my other videos, but increase in POMC, downstream, high MSH. Please remember that. All right, I couldn't find a slide that ended up conveying the point which I wanted to, so I just created it, okay? We're going to be talking about ADH and aldosterone. ADH is secreted from the posterior pituitary, and it's all about water. It is made in the supraoptic nuclei in the hypothalamus. So I like to say supraoptic, here are my eyes, here are my kidneys. I look down on my kidneys, supraoptic nuclei. ADH has two receptors, V1, V2. If we talk about the V2, that is at the level of the collecting duct in which you have your principal cells, increasing the aquaporins, and you're bringing in a lot of water. High water reabsorption is going to decrease your serum osmolarity and serum sodium, and you're going to have a lack of diuresis because you have anti-diuretic hormone active, so no diuresis, and a low ANP because they're complementary. There's that spaced repetition. So whenever you have too much ADH, you have too many aquaporins, and thus you have hyponatremia because you have too much water coming in, and that's diluting your body. In diabetes insipidus, whether it's nephrogenic or central, what you want to recognize here is that you don't have any aquaporins. No aquaporins, you are going to have very dilute pee because all that water stays in the urinary tubule, and thus your urine osmolarity is low. And remember that because you can't reabsorb free water, your serum osmolarity is very elevated. Your body's super concentrated, and that's why these patients present with polydipsia, because they have a high serum osmolarity that triggers their osmoreceptors to trigger thirst. When we think about aldosterone, it's all about sodium. It's made in the zona glomerulosa. It's a byproduct of the RAS system. And we talked a little bit about the effects where aldosterone brings in sodium via the ENaC channels and makes you pee out potassium and hydrogen ions. And the potassium and hydrogen ions, very high yield. So let's go through the extremes. We talked about it. High aldosterone states, you're bringing in a lot of sodium, you're bringing in a lot of water with it, and you're peeing out a lot of potassium. So your serum potassium is going to go down. You're also peeing out a lot of H+. So what's your pH? Well, your pH is going to be very elevated because you're just peeing out acid. So you have a metabolic alkalosis. When you don't have much aldosterone, you're going to be salt wasting. So you're going to be very hyponatremic. These patients are going to have low blood pressure, but what are they going to retain? You can't pee out potassium, so it's going to stay in your body. You can't pee out H+, so it's going to cause you to have a non-anion gap metabolic acidosis. Let's go ahead and have you go through this question. Stick with me. A patient is diagnosed with brain death. Urine output is very elevated. A central cause is suspected. What do you think is going to be seen in this patient? Go ahead and put your answer into the chat box. Wonderful. A lot of you are saying central diabetes insipidus, and you're absolutely correct. In central diabetes insipidus, you don't have ADH. As a result, you are going to have no aquaporins. No aquaporins means that in your urine, there's going to be a lot of water. So your urine osmolarity and the spec grav, which is a kind of directly proportional to your osmolarity, your spec grav is going to also be low, but you're hypernatremic in the blood because, again, no aquaporins. You can't bring in that free water. And thus your serum sodium is going to go up, and thus your serum osmolarity is going to go up. Very important for us to know, everybody, that the primary driver of serum osmolarity is sodium concentration, especially if you have normal kidney function and if you have normal glucose regulation. Serum osmolarity is equal to 2 times your sodium if you have normal kidney and you're not in DKA. After traumatic brain injury, a patient has seizures. Oh gosh, he's hyponatremic. Well, seizures, hyponatremia, and brain injury, SIADH is your diagnosis here. Too many aquaporins. Too many aquaporins, well, you're bringing in a lot of free water. And if you're hyponatremic, you are going to have a low serum osmolarity. If you're going to have a lot of aquaporins come in, well, you are going to have your urine osmolarity go very, very high. And urine-specific gravity, as a result, is going to also be very high. So your best answer here is going to be B. A patient with bipolar is controlled on lithium. The patient has a fine tremor and increased urine output. Signs of, most likely, nephrogenic diabetes insipidus. Remember, lithium also is going to have a narrow therapeutic index. Compared to serum, which of the following urine tonicities is seen in this patient? So if I have central diabetes insipidus, what I do know, and excuse me, pause, if I have nephrogenic diabetes insipidus because of the lithium plugging up the aquaporins, if I have nephrogenic diabetes insipidus, I know that my collecting duct is not going to be able to insert and have awesome aquaporins. As a result, my P is very dilute because now whichever aquaporins are in the collecting duct, they're plugged up by lithium. If they're plugged up by lithium, you can't bring that free water in. And so all that water stays in the P. So my medullary collecting duct becomes hyponatremic. Overall, I have no concentrating ability whatsoever in all of my glomerulus thanks to the lithium toxicity. So I have very, very dilute P and nephrogenic DI. But what's important always, and the explanation is a little bit longer, but remember always, because the proximal convoluted tubule usually is going to be in the cortex and not the medulla, the concentration in your proximal convoluted tubule is mostly going to be isoosmotic. And that's super important, that the concentration in your proximal convoluted tubule is going to be isoosmotic. So your best answer is going to be, and I'm sorry that both of them were correct, but your best answer is going to be A. Very high yield for us to know that it's isoosmotic in the PCT, juxtaglomerular apparatus, and your medullary collecting duct. They're going to be both hypoosmotic, especially in nephrogenic diabetes insipidus. All right. A patient with osteoarthritis takes chronic NSAIDs. Which of the following is most likely to be seen? If you have chronic NSAIDs, you are going to have an inhibition of COX because NSAIDs are going to inhibit COX. So I know that my COX activity is going to be low. And I know downstream my prostaglandins are also going to be low. If my prostaglandins are low, my afferent arteriole suffers. Not my efferent, no way. My efferent is totally fine, right? So my efferent is not really mediated by my prostaglandin concentration. It's just my afferent. And what happens is that the afferent arteriole is going to narrow. So the diameter is going to decrease. Why? Because normally prostaglandins dilate the afferent arteriole. So if we look at this schematically, we notice here that the blood flow is going to come in at the afferent arteriole. Low prostaglandins, you are going to have, because why do you have the low prostaglandins, by the way? NSAIDs, we just talked about that. You're going to have constriction at your afferent arteriole. and thus a reduced GFR. If you have a reduced GFR, that means that your creatinine clearance is poor, and thus your serum creatinine is going to be very elevated. Okay, and they can modulate all of these variables for you, but just know the concept that afferent arteriole is under the control of prostaglandins. Efferent is under the control of angiotensin 2. Speaking of angiotensin 2, let's go through this question. A patient with congestive heart failure takes lisinopril. Pharmacological agent, recall the mechanism of action. Lisinopril is an ACE inhibitor. So downstream, it's going to inhibit angiotensin 2. If it inhibits angiotensin 2, what's going to happen? Well, my efferent arteriole is not going to stay nice and tight. It's going to get loosey-goosey. No angiotensin 2, no tight efferent arteriole. My arteriolar diameter is going to be very high. Remember that if I have angiotensin 2 being affected, my afferent arteriole, there's not going to be any effect. Afferent arteriole is going to be all related to prostaglandins. And because I have an ACE inhibitor, my renin is going to be high. And the reason why is because ACE is going to be inhibited, but renin is actually proximal. And thus my renin is elevated. All right, why don't you go through this question with me? A patient with congestive heart failure takes losartan. Which of the following is most likely to be seen? Renin, angiotensin 2, and aldosterone are your markers. What do you think is the best answer here? Wonderful. Losartan is an angiotensin 2 receptor blocker. If you have an angiotensin 2 receptor blocker, your angiotensin 2 levels, because it's proximal, angiotensin 2 is proximal, that's going to be elevated. And your aldosterone is going to be low because now you are not going to have the downstream effects of angiotensin 2 whatsoever. And thus, the best answer here is going to be C. Please note the renin-angiotensin-aldosterone system. Renin is secreted by the juxtaglomerular apparatus, specifically that macula densa area. You convert angiotensinogen from the liver to angiotensin 1. ACE is going to be in the lungs. Angiotensin 2 does two things. It increases aldosterone, and it is going to vasoconstrict. Particularly, it's going to vasoconstrict at your efferent arteriole and at your precapillary arteriole in your systemic circulation. And also, aldosterone and angiotensin 2 combined, they increase the levels of ADH downstream as well. Our last section today, we only have a couple questions here, but I thought that this would be very important. How many of you all are ready to cool down this session today, end it strong? Go ahead and type in yes into the chat box. All right, Ashley, Larev, Nicole, Angela, Rockefeller, Rutha, Larry. It's hard to keep up because you guys are just crushing it. Hey, thanks so much, guys. Let's go ahead and keep going. Hematology, we only have a couple more questions here. A patient is noted to have nosebleeds and heavy menses, so signs of mucosal bleeding. There's a family history of increased bleeding, especially after NSAID use. Again, this is all mucosal bleeding that's hereditary. So this is von Willebrand's factor disease. In von Willebrand's factor disease, only primary hemostasis is messed up. Only primary hemostasis is messed up. And thus your bleeding time is the only thing that is going to be high. Remember that sometimes von Willebrand factor loves factor 8. So technically at times, von Willebrand factor being low, factor 8 is low, and that affects your intrinsic clotting cascade. And specifically, your PTT may be elevated in von Willebrand factor disease. So watch out for this on the physical exam. Primary hemostasis disorders, that's all platelet issues, platelets and bleeding time. They're going to have more mucocutaneous bleeding in your physical exam, okay? So you're going to have a lot of gum bleeding, menorrhagia, petechiae, purpura, ecchymosis. Whereas secondary hemostasis, that's all clotting cascade. So you're worried about the values PT and PTT. And these patients are going to have hemarthrosis or blood in the joints. Know that your quintessential disorder for both primary and secondary hemostasis abnormalities is DIC. A patient with chronic kidney disease has missed 8 weeks of dialysis. The patient has bleeding gums and petechiae. So is this signs of primary or secondary? Answer is primary hemostasis is messed up because it's mucosal bleeding. So you're worried about platelets and bleeding time. And so as a result, whenever you have uremia, i.e. you have a high BUN, typically greater than like 100, you have what we call a qualitative platelet dysfunction. It's not the platelets themselves that are down, but it is a fact that you can't activate those platelets. Those platelets don't work, and your primary hemostasis is affected, and thus your bleeding time is very elevated, but your platelet count and your PT, they're not affected. So qualitative platelet deficiency with a high BUN, heavily seen clinically and tested on the USMLE. All right, I believe this is our second to last question. A patient presents with a history of acute promyelocytic leukemia. They present with sepsis. The patient's peripheral smear is shown. Go ahead and take a look at that peripheral smear. What do you think is the answer here? Awesome. If you're worried about our rods, DIC, especially in the setting of sepsis, you're absolutely correct. And DIC is going to be an issue in both primary hemostasis, so platelet count and bleeding time are messed up, and secondary hemostasis because you get microvascular consumption of your clotting factors, and thus your PTT is going to be elevated. All right, ladies and gentlemen, last question of the day. Let's go through this together. A neonate presents for autopsy. Brain cross-section is shown. This is a gross pathology of what? Of the ventricles of the brain. And what do you see? Well, you see asymmetry in the ventricles. The baby was born at home with no prenatal care. So if they don't have any prenatal care and we're having intraventricular hemorrhage, you're worried about vitamin K deficiency, hemorrhagic disease of the newborn, and you're going to have vitamin K deficiency. No vitamin K, no activated 2, 7, 9, 10. Thus, your PT and PTT are going to be very elevated, but this is not an issue with primary hemostasis. It's not an issue with the bleeding time. And so, because it's a coagulopathy, PT is going to be your extrinsic cascade, which is factor 7. The remaining 2, 9, and 10 are going to be PTT. And again, no vitamin K in this child, and thus they're predisposed to bleeding. Ladies and gentlemen, I am so grateful for each and every one of you. I just want to say from the bottom of my heart, big thank you to you all. Stick around. I just have a special announcement. We're going to summarize real quick. Number 1, prediction is key. Go with your low-hanging fruit and branch out. Really important for us to know here. I have a special upcoming event. I'm going to link it into the chat box. Please remember that this upcoming weekend, okay, I'm going to be hosting an important course, and that is going to be the Advanced Test-Taking Strategies webinar. I linked it in the description. It's a one-on-one tutoring-like experience in the comfort of your own home. We just went through one question type today, and that is going to be arrow questions. But in the Advanced Test-Taking Strategies, when you register, you will get a Notion study template. You will get access to my 1.0 course, which is the Test-Taking Strategies and Productivity course. Absolutely free. This course is usually $155, but for your registration, you get 6 hours of your live question breakdown, access to the recordings, and you get a whole nother course and a study template just for signing up and joining me for this live, nice, intimate review. I would really encourage you to sign up today. Please make sure that you stay focused during this next weekend's webinar. You get that study schedule when you do sign up, because I'll activate your course and I'll activate the study plan when you get signed up. And here are going to be the things we're going to cover. How are UWorld and NBME questions written? How do we get the most out of UWorld? How do I review a block efficiently? When do I mark a question? How do I deal with narrowing down to 2? How do I approach experimental questions? How do I approach anatomy questions, genetics questions? What are some key physical exam signs that they put in the USMLE? How do I approach images? This is going to be an advanced course, and I encourage you to watch my test taking strategies course that I have up right now on my website that comes with the registration for this course. That course you should watch before attending next weekend's advanced test taking strategies. I'm going to really make sure that as we go through this journey together, we optimize your test taking psychology. This is a mental game, and I want to address that when I'm preparing you as a student, because genius is not the realm of genetics, what you're born with. Genius is the realm of practice, and we're going to deliberately practice together in this advanced test taking webinar. Other resources, which many of you are familiar with, that I would encourage you. The number one resource right now for dedicated study, as well as during classes, is pass-fail course. My pass-fail course, under 50 hours, you get the highest yield concepts to help you pass the USMLE Step 1. I did also put custom UWorld questions to optimize your retention after a video. Watch the video, you type in the questions into UWorld, so you do those focus questions in a tutor mode. Also, with the pharmacology section in my course, I integrated pathology into it. I want you to know that griseofulvin, yeah, it's an antifungal, but I want you to know it could be a trigger in acute intermittent porphyria. It's a CYP inducer, and all of the pathologies that it's related to. Again, this customized way of learning allows for you to optimize your retention. So please go ahead and join the HiGuru family. I have many courses, higuru.com. I'll see you next weekend for that live webinar. And before you leave, make sure you share this webinar or share HiGuru on your social media, either YouTube, Reddit, Instagram, Facebook. Feel free to email me, rahul@higuru.com. I would love to hear from each of you, and thanks for spreading the word. Look forward to also seeing a review on my Trustpilot page, which again, if you just Google HiGuru Trustpilot, if you don't mind leaving an honest review, again, I just want one student to pass on the word to the next. And before you leave, as we end today's webinar, go ahead and type in one thing that you learned from today's webinar. I would love to hear one thing that you learned from today's webinar.